Today I would like to talk to you about NAP5. NAP5 is the National Audit Project number 5. This is a very large project which the College of Anaesthetists of Ireland did in conjunction with the Royal College of Anaesthetists and the Association of Anaesthetists of Great Britain and Ireland. The objectives of NAP5 were to determine how many cases of accidental awareness under general anaesthesia occurred in the study period in both Ireland and the whole of the UK. Accidental awareness under general anaesthesia is a rare event. The numbers were 300 cases in the UK and we looked at 11 cases from Ireland. This gave us an incidence in Ireland of 1 in 20,000 compared to the UK, which was 1 in 19,000. There were 11 cases of AGA, that is accidental awareness under general anaesthesia, identified in Ireland. In 5 of these cases, neuromuscular blockade was used. 2 cases occurred at the induction at the beginning of anaesthesia. The first of these was a rapid sequence induction in a caesarean section patient who had had a failed regional technique. The second case was a failure to turn on the vaporizer when moving the patient from the anaesthetic room to the operating theatre. There were 2 cases of drug error. One was giving a relaxant, succinylcholine, instead of fentanyl for a case of sedation. The second was giving a non-repolarizing relaxant in the IV fluids instead of a non-steroidal anti-inflammatory. In about 51% of cases, this led to distress. In the majority of cases, however, this was very short-lived, and in about 41% of those patients, they developed psychological sequelae. One factor that came out very strongly in the report was the use of neuromuscular blockers and its influence on AGA. During anaesthesia, we know that neuromuscular blockers are used in almost 50% of all cases. We know also that 93% of the cases of accidental awareness occurred when a neuromuscular blocker was used. This is because a paralysed patient, having received a muscle relaxant, is unable to signal that they are aware. Drug errors featured in 10% of the reports to NAP5. When that occurred, the psychological distress and sequelae were greater than in other groups. One of the differences we found in the Irish study versus the UK study was the use of depth of anaesthesia monitoring. Depth of anaesthesia monitoring is used in 7.7% of cases in Ireland versus 2.3% of cases in the UK. The report outlined 64 recommendations to help prevent AGA but also to manage it when it occurs. First of all, at the preoperative visit, optimally informing the patients and consenting the patients for anaesthesia. Secondly, the introduction of a simple checklist to complement the WHO Safe Surgically checklist, which we already use, and also an awareness support pathway to use if a patient comes to your attention who has had an episode of accidental awareness. In summary, this is the very first ever large anaesthetic audit conducted in Ireland and the very first study on accidental awareness under general anaesthesia. It involved the whole anaesthetic community and 100% of all the public hospitals in Ireland. We hope that implementation of the many recommendations in this report will lead to reducing the incidence of AGA and to managing it more optimally if it occurs. In addition, we will be incorporating the recommendations into all our teaching programmes in our CPD for consultants, and the aim of this study was to shine a light on a topic that is of grave concern to both anaesthetists and patients. By doing the study and by implementing the recommendations, we hope to make anaesthesia safer for our patients.